Ladies and gentlemen, we are going to call to order the Military Personnel Subcommittee of the Armed Services Committee. We welcome our witnesses this afternoon. We will have some complications in this hearing because there will be a series of 5 votes that the House will be taking, so we will recess for a period of time and then come back. Hopefully we'll be able to get through the first panel. The taxpayers spent more than $50 billion each year on the military health system, which provides health care services to 9.6 million beneficiaries, including service members, dependents, and retirees. This sizable investment should buy timely, safe, high-quality care for our service members and their families. However, I'm not convinced that the military is delivering on this sacred obligation. The 2017 NDAA reorganized the military health system and standardized clinical quality processes. Before the reform, the Army, Navy, and Air Force each operated several healthcare systems, and the military had 24 different policies on patient safety and quality. Now, the Defense Health Agency oversees all medical treatment facilities, and since 2019, DoD has a single policy on patient safety and quality. But despite these changes, I have not seen evidence that real improvement has occurred. In fact, I hear too often about medical errors that cause grievous harm to patients and quality assurance investigations that drag on for years while the suspect providers continue to practice. Our first witnesses include 2 families that have been irreparably and devastatingly harmed by inexcusably poor military health care. I want to thank you for coming forward and sharing your deeply personal stories. You are representing yourselves, your families, and countless others who could not be here today. I want to hear from you and how you and your families were treated during and after your medical ordeals. Our first witness is Des Del Barba. He had a dream to follow his family in service to his country. Instead, he found a toxic environment in basic training where he became very ill. The command repeatedly ignored his symptoms and shamed him. When he finally got medical treatment, misdiagnosis and inexplicable additional delays in treatment resulted in an unimaginable set of circumstances for what was a healthy 21-year-old. 43 surgeries, loss of a leg, and loss of a dream for a career in the military. This injury didn't happen in combat. It didn't even happen during training. Instead, it happened because providers failed to act in a timely manner. I also want to recognize Mr. Derek Lucky, whose 19-year-old daughter, Danielle, died in 2016 after the Navy failed to diagnose her condition while she was aboard the aircraft carrier USS Reagan. Her symptoms were also repeatedly ignored, and she paid the ultimate price. I cannot tell you how grateful I am that you are both here to share your stories. You two represent countless victims of poor quality medical care, and I thank you. Our GAO witness, Ms. Sillis, will shed light on whether the Defense Health Agency is adhering to its own clinical quality management procedures, including provider credentialing, investigating medical errors, and holding accountable providers who fail to meet the standards of care. When our service members suffer from poor quality medical care, when doctors fail to provide the standard of care or woefully ignore symptoms or conditions, we need to make sure that there is a system in place to both prevent the incident from happening again and hold the providers accountable. And that's what we want to hear about from the second panel. To Lieutenant General Place and the Surgeon General of the military departments, we want to know how you are holding incompetent and negligent providers accountable. How are you implementing changes to improve patient safety, both in the military hospitals and in operational medical environments, including ships? How are you making sure the doctors and nurses have the appropriate credentials to provide health care? In our country, we rightfully revere service members for their bravery and their sacrifice. It is incomprehensible and shameful that we cannot ensure they have the quality medical care they deserve. I also want to point out that my efforts to allow service members to file claims against the military for instances of medical malpractice aren't only a matter of justice, they are about accountability. And I'm frustrated, to say the least, that the DoD has been so slow to implement the Stay Skull Act that Congress included in the 2020 NDAA. There are few incentives better than the threat of legal action to push an organization to change its behavior. Before hearing from our first panel, we want to hear from Ranking Member Gallagher and give him an opportunity to make his opening remarks.
Well, I thank the Chairwoman, and I want to thank both of our panels for being with us today, and a special thank you to Mr. Lucky and Mr. Del Barba for your willingness to share your personal stories and experiences in an effort to help us make the system better. In preparing for this hearing, I looked at some statistics from the National Institutes of Health and found that approximately 400,000 hospitalized patients experience some type of preventable harm each year, and that medical errors cost approximately $20 billion a year, and that medical errors, furthermore, in hospitals and clinics result in approximately 100,000 people dying each year. Within the Department of Defense, a 2014 review found that, quote, while the military health system delivers safe, timely, and quality care that is largely comparable to care delivered in the civilian sector, the MHS demonstrated wide performance variability, with some areas better than civilian counterparts and other areas below national and DoD benchmarks. I understand that reforms in the NDAA, as well as the internal process improvements of DoD, are making a positive impact, but the bottom line is that the military health system is not where we need it to be. One thing that I believe can be done is to attack that variation at every turn, whether it's in the operating room, in the clinic, or on the battlefield. There are many examples within the military of high reliability organizations that focus on eliminating variation in planning until service members can't get it wrong. These organizations empower meritocratic ideals that teach us that every person has an important role on the team based on their performance and their professional acumen. Some examples include military aviation, nuclear propulsion, and special warfare communities. I'd also like to add, although not the focus of today's hearing, that wargaming is actually another way to evolve our military culture in eliminating variation and a never-ending quest to defeat our adversaries. And sometimes we focus so much on the high-end weapon systems, we forget that healthcare is part of our ability to be ready to deter and, if necessary, win our nation's wars. So I'm really looking forward to better understanding the challenges the military health system has today, how we can embrace that high reliability organizational culture, and any recommendations that we should be thinking of as we gear up for another NDAA cycle in order to ensure that our outcomes are better than they are today. Thank you.
Thank you, Mr. Gallagher. I ask unanimous consent to allow members not on the subcommittee to participate in today's hearing and be allowed to ask questions after all subcommittee members have been recognized. And we welcome Mr. DeSagne, and I believe Mr. Westrup is here, Dr. Westrup is here as well. I ask unanimous consent that the chair be authorized to declare a recess at any time. Is there objection? Without objection, it is ordered. Each witness will have the opportunity to present his or her testimony, and each member will have an opportunity to question the witnesses for 5 minutes. We respectfully ask the witnesses to summarize their testimony in as close to 5 minutes as you can. Your written comments and statements will be made part of the hearing record. With that, Mr. Des Del Barba, you may make your opening statement. You have to push that little button there to turn on the microphone. I don't think it's on yet.
Hello? Okay. I apologize.
That's all right.
Thank you, Congresswoman Spear. My name is Des Del Barba. Before I begin, I'd first like to thank Chairwoman Jackie Spear and everyone on the subcommittee for allowing me to speak before you all today and tell my story. I'd also like to thank my parents, Comnie and Mark Del Barba, and my girlfriend, Julie Ruiz, for being here with me today from the very beginning. I'd also like to thank my sister, Drissa Del Barba, who is unable to attend, and lastly, my legal team, Daniel Maharaj and Elizabeth Zwibble, for supporting me throughout this journey. Many people have dreams and aspirations of having a career in tech, medicine, engineering, and law. I had dreams and aspirations of having a career in the U.S. military, and it was something I knew I always wanted to do from a very young age. I wanted to join the military right out of high school. However, I was guided to pursue a bachelor's degree first before getting commissioned as an officer. I was an extremely healthy and athletic 21-year-old man before I enlisted in the U.S. Army. I never had any health issues besides I've never had any health issues besides an ACL tear on my right knee. The Army is the only branch that makes it a requirement for their officers to complete basic combat training before they can attend officer candidate school. I was accepted into the OCS program as I had a few semesters of college left to finish before obtaining my degree. I decided to take a leave of absence from college to complete basic combat training, return to school, then upon graduation from college, attend OCS. I shipped out to Fort Benning on January 7th, 2019, and like many young men and women, I was excited, energetic, enthusiastic, and even anxious for this new adventure in my life. I was assigned to Bravo Company, 1st Battalion, 46th Infantry Regiment. However, it only took 35 days for the military to destroy my life. I was left grossly neglected in by the U.S. military healthcare system and by my basic training leadership at Fort Benning, Georgia. As a result of the neglect I experienced, I have physically endured a total of 43 surgeries. Over half of my right glute has been debrided and skin grafted. Both of my underarms have undergone debridement and skin grafting. I have an above-knee amputation on my left leg, while my right leg has been severely debrided and skin grafted, leaving me with 70% muscle and tissue damage. In order to somewhat restore these 5 major areas of my body, I had skin donor sites on my chest and back. Mentally, I'm now diagnosed with severe PTSD and depression. Today, as I sit in front of you all, 3 years and 19 days have passed since I have answers about what has happened since I contracted necrotizing fasciitis at Fort Benning. It's been 1,143 days, and I still have no clear answers on the status of any quality assurance investigation that may or may not have been initiated promptly. What happened to me did not have to happen. This was preventable. I can sit here and speak all day about what happened to me, but my pictures will put my words into perspective of the damage that has been done to my body and my mind. Please see the attached photos for a better understanding of what I went through and what could have been avoided had the medical providers at Fort Benning given me adequate medical attention. If I was your son, if I was your brother, if I was your loved one, would you sit stagnant waiting for answers? I would hope not. You'd fight for their rights, and you would never stop until the questions are answered and the responsible people are held accountable. I understand that the medical quality assurance is managed by the military medical community. I understand that this takes time and patience. However, my medical records from Fort Benning total less than 100 pages, and I cannot seem to understand or comprehend how the Army has taken over 3 years and still has not concluded the QAI in my case. I've enclosed with my statement all the correspondence I've received from the Army Command regarding the status of my QAI for the committee to see how convoluted this process has been and how inconsistent the Army is when responding to inquiries made. I would pose the question, how can the military say it is adequately providing medical quality assurance for service members like myself? I'm here today not only fighting for myself, but for all other service members that have been subjected to an adverse event at a military treatment facility center and have never had a proper or appropriate quality assurance investigation. This is a grave injustice for our service members, and this is the least that they deserve given that some of them are no longer here as a result. I cannot stress the negative emotional impact this has caused on myself. Not only did I lose a limb, I also lost my identity, my self-esteem, and my confidence along with it. Activities that are supposed to be fun and enjoyable for someone in their 20s became a mental burden. Hiding behind a fake smile every time I am around others while having feelings of true unhappiness on the inside became normal. Having thoughts of, it would be better if I just went to sleep and never woke up, was something I was hoping would happen to me every single night before bed. As the saying, life goes on, my life will go on. I will eventually find the strength mentally and physically to work past this horrendous time in my life. However, this has reshaped my identity as a human being. Daily things that you all take for granted, such as putting on your shoes before work, taking a walk around your neighborhood, going for a dip in the pool when it's too hot outside. These are all things that I'm not able to do either at all or as easily anymore as a 24-year-old man. I would never wish what I went through upon anyone, but unfortunately may not be possible, seeing that those responsible for the poor medical care I received are still employed by the Army to treat more service members. I ask you to take away the feeling of motivation from what I have shared here with you today, the motivation to want a better system that should be at its finest for its men and women who want to serve this country. Thank you for your time and attention, and please see my written statement for a full accounting and timeline of what happened to me. I'm happy to answer any questions.
Thank you, Mr. Del Barba. Extraordinary courage that you've shown. I want my colleagues to know that in your binders are pictures of his injuries, and they are truly shocking. Mr. Lucky, you're recognized.
Good afternoon. Good afternoon.
Could you make sure your microphone's on?
Good afternoon.
I think it's on.
Should light red.
Good afternoon.
Maybe put the microphone a little bit closer. Yes, there you go.
Good afternoon, Chairwoman Spear and members of the committee. My name is Derek Lucky. I'm from Pittsburgh, California. I am joined today by my wife, Annette. We are the parents of the late seaman, Danielle Lucky, who died October 10th, 2016, from sepsis while serving on the USS Ronald Reagan. We were invited to appear today to share what happened to Danielle while she served our country. We were invited to appear today to share what happened to Danielle while she served our country. First, let me say I am not a lawyer or a politician. I have never done anything like this before. However, I am here today to share with you the tragedy of Danielle's death. She did not die in combat or any military operation. She died from gross negligence of the medical providers on the ship she served, the USS Ronald Reagan. Her death was very preventable. Instead, she died in excruciating pain instead of being properly treated. When Danielle came to me and said, "Dad, I want to join the military and serve my country," she wanted to join the Navy to start a career as a sailor on a ship. When she approached me, I said, "I am concerned for you." She said, "Dad, I will be okay." With that big smile I remember so much, a smile I will never see again. Little did I know, on October 10, 2016, I would get that knock at the door at 9:03 a.m. telling me my daughter was dead, not from bullets, but from sepsis. Like many who have children who have served in the military, we live in fear of two officers knocking at our door. Danielle was not in combat. We were crushed when they told us she had died of cardiac arrest. We thought it was impossible. How could my daughter die of cardiac arrest? Our lives changed forever. Danielle died on the USS Ronald Reagan, not at war. This tragedy was completely avoidable. Her death was the result of gross negligence, malpractice. If the medical providers on the USS Ronald Reagan had given her a simple treatment of antibiotics instead of turning her away, she would be here today. When we reached out to attorneys around the country to represent us, they said no, that we couldn't do anything. Someone told us to reach out to attorney Natalie Quam. They said she is a strong fighter for our military. We did, and she was willing to help us seek justice for Danielle. Ms. Quam told us that you, Chairman Spear, are an incredible advocate for our military and that you are the champion of the Richard Stiesel Military Accountability Act. So today, I did come here to share with you the tragedy of our daughter's death and to share with you what is wrong with the system you created to seek justice when sailors like my Danielle died when they are victims of medical malpractice. We all believe when Congress passed the SFC Richard Stiesel Military Accountability Act under your leadership, we would finally have justice and accountability for victims like Danielle. Unfortunately, we could not seek justice for Danielle as you, this Congress, has intended and we hoped. Sadly, we learned from our attorneys for military.com that despite your hard work, Chairman Spear and Congress and intense Department of Defense has decided not to allow claims from sailors on vessels or ships like Danielle's. That is not what Congress intended. It is the opposite. I have also learned that they will not allow claims by sailors or soldiers when they are treated at military facilities outside the United States in places like Italy, Germany, and England, where we have big U.S. military hospitals. So just because a military hospital is not in the U.S., the care doesn't have the same medical standard. This is wrong. The DOD issued guidelines that do not align with what Congress intended. Justice for victims of medical malpractice. Worse, I am told if a sailor like Danielle were to file a claim and be denied, the appeal of the denial goes back to the panel made up by either Army, Navy, or Air Force. So the military decides the cases and the appeals. That's like the home team getting to be their own referee in a football game. This is not, it's just not fair what I think you intended. These denials should be heard by an independent federal judge like other federal claims. That would be fair. Chairwoman Spear, the law as written today can't bring justice to Danielle or me or my wife, but you can make changes that would allow for these other problems like the appeal and where the hospital is located be corrected. Without these changes, the military will continue policing themselves. Without these changes, the military will continue policing itself. The military will decide if they are right or wrong, and worse, they will also determine the appeals if someone like me were to lose the case. I urge you to stop this now and correct these problems. I know you and other Congress members care about our military and want them to have the best medical care possible. And when that care causes their death or harm, they should be compensated for the harmful, for that harmful maltreatment. Please make these changes and bring our military and our families justice today. Danielle was robbed of her life and her career. Let her mistreatment and death remind us that our military and families deserve justice now. Please fix the Stiesel Act to work the way you intended to bring justice to victims and their families. Thank you.
Thank you, Mr. Lucky. Again, this committee mourns with you the loss of your daughter. Ms. Silas, from the General Accountability Office, you are recognized.
Thank you. Chairwoman Spear, Ranking Member Gallagher, and members of the subcommittee, I am pleased to be here today to discuss GAO's ongoing work reviewing DoD's monitoring of providers' qualifications and competence in military medical facilities. My testimony today summarizes preliminary observations we have developed during the course of our review. DoD provides healthcare to over 9 million beneficiaries through its military health system and employs a variety of physicians, dentists, and other providers that provide a range of healthcare services, from routine examinations to complex surgical procedures. As such, it's imperative that DoD ensure that these providers are delivering timely, quality care to military service members and their families. and then any concerns that may arise about the quality and safety of care being delivered by these providers is immediately addressed. Like other healthcare systems, DoD is responsible for ensuring that their providers deliver safe care to patients. Since the Military Health System's review of DoD provider quality of care issues in 2014, Congress has required DoD to transfer management of domestic medical facilities from the military departments to DHA. In 2019, DHA issued standardized clinical quality management procedures intended to ensure that individual providers are qualified and competent to deliver safe, high-quality care to patients across all military departments. GAO is currently reviewing procedures that occur under DHA's clinical quality management, credentialing and privileging, focused professional practice evaluations, and the review of potential compensable events, that is, patient safety events that could result in payments to the patient or their families. And generally, we've found a number of instances where facilities and DHA were not adhering to procedures. First, as part of credentialing and assigning clinical privileges to providers, DHA policy requires military medical facilities to verify a provider's qualifications such as education and licensure when providers are first onboarded at the medical facility, and then to periodically assess the provider's credentials and privileges thereafter. However, as part of our ongoing review, we have found that the selected facilities were not always following the DHA credentialing privileging procedures. For example, we have learned that facilities were not consistently verifying that all of a provider's medical licenses were valid. In addition, it appears that about 3/4 of the applicable providers, these facilities do not have documentation that ongoing evaluations were conducted every 6 months as required. Second, military medical facilities are also required to conduct focused professional practice evaluations for cause, which are conducted when concerns are raised about a provider's care. Our ongoing review indicates that for the 20 focused evaluations we reviewed, documentation that 2 key requirements, criteria, and metrics were not consistently documented in the focused evaluation plans. Both are important to determining whether the provider has successfully completed the evaluation. Lastly, based on our work today, DHA has not always completed reviews of patient safety events that could potentially result in compensation or did eventually result in payments to the patient or their families. For example, for the 12 cases we identified that did result in payments to patients or their families, for about half of the cases, DHA reviews were not completed within the 270-day requirement. And further, none of these cases were reported as required to HHS's national repository that contains information on adverse actions taken against the provider and provider medical malpractice payments. Finally, our preliminary observations indicate that DHA does not sufficiently monitor facilities' adherence to its clinical quality management procedures. For example, DHA officials told us they run some reports related to credentialing and privileging from a database, but those reports are pretty limited. Furthermore, the database does not include all required documentation, such as the documents related to the provider ongoing evaluations. We also learned that DHA has not begun monitoring of facilities' implementation of its reviews of potential compensable events. Instead, DHA is focusing on only monitoring compensable events cases that have resulted in payments. As DHA continues to implement its clinical quality management procedures, ensuring DHA policy and procedures are properly adhered to by the military medical facilities can help to ensure that service members, military retirees, and their families receive safe, high-quality care. And when the care does not meet those standards, DHA can hold those providers accountable. We will continue to assess these issues as part of our ongoing work, and we'll plan to make recommendations as appropriate. Thank you. That concludes my prepared statement, and I would be happy to answer any questions that you might have.
Thank you, Ms. Sillis. We are in the middle of a roll call, but there are still 300 members who haven't voted. So what I'd like to do is give members the opportunity to ask some questions. Mr. Gallagher?
I'll start with Ms. Sides. Thank you, Madam Chairwoman. Can you tell us more about the shortcomings GAO found in DHA's efforts to monitor medical facilities' adherence to procedures? Why is this important, and what more could DHA be doing to make sure its facilities are adhering to those procedures?
Certainly. So as I mentioned, we looked at 3 different types of procedures. We looked at credentialing, privileging, which we looked at a sample of 100 providers from 4 military treatment facilities. We found instances of where during the credentialing process, the facilities were not always verifying providers' licenses, as I mentioned in my testimony. So for example, a provider could have licenses in multiple states, and we would find that some of the licenses haven't been verified. We also looked at ongoing professional evaluation or practice evaluations, and these are routine evaluations that occur every 6 months. And we found that about 3/4 of the providers did not have documentation that these were even conducted. The other procedures that we looked at were under our focused professional evaluations for cause. We looked at 20 evaluations from the 4 military treatment facilities. And we found, for example, that facilities were rarely documenting all of the required elements that are needed to determine whether or not a provider had successfully met all of the requirements for the evaluation. And then lastly, we looked at patient safety events. We looked at 2 groups of events. We looked at potential compensable events. We identified 19 from the 4 facilities included in our review, and we found 2 issues of non-adherence. One, at the beginning of the review, facilities are supposed to consider taking an adverse privileging action against a provider if the safety events were particularly egregious, and we found that there was no documentation that any consideration was ever taken. We also found that there was issues with kind of meeting the timeframes, the required timeframes for these reviews. The facilities are supposed to conduct these potential compensable event reviews within 180 days of notification that the event had happened. And we found about 80% of those cases were not completed within that required time. We saw that these cases, the days ranged from 91 to 546 days in some instances. For the second group of patient safety events that we looked at, we identified 12 patient safety events that resulted in payments to either the service member or their families. We found that DHA did not complete these reviews for reporting out on these reviews within the required time frame, which was 270 days. We found that about half of the 12 cases were incomplete and exceeded that time frame. But in particular, what we found too is that for those reviews that were not completed within the 270-day time frame, none of those cases or those providers were reported to the National Practitioner Data Bank, which is HHS's repository for information on provider quality care issues. So that if a provider has an adverse privileging action that's taken against them, they would be reported to HHS. And in this instance, there's a requirement within DHA procedures that if these patient safety events that have resulted in payment exceed the 270-day requirement, then they need to be reported to the National Practitioner Data Bank.
Well, thank you. I was going to cede my time to Mr. Jackson, but I'm almost out of it. But we have, I think, 300 people left to vote, so you should have a full 5 minutes if we go. But so in the 50 seconds I have remaining, I just would ask both Mr. Lucky and Mr. Del Barba, what is the single biggest lesson you've learned from this terrible and tragic experience that you've had with the military healthcare system? In either order.
Sir, the military healthcare system does not listen to the needs of the service members. It's that simple. We go and we ask for help and we are denied treatment.
Mr. Lucky.
My daughter shouldn't have to be denied medical. She signed up to serve her country. That's all she wanted was to serve her country, and to be denied medical, that's not right.
Thank you.
And in both of your cases, a simple antibiotic given over a period of 5 to 7 days would have solved the problem, correct?
Yes, correct. And I actually went to sick call and physical therapist a total of 6 times before my body went septic.
And Danielle, she went to medical several times and was turned away. And each time it got worse.
Thank you. Ms. Houlihan, you're recognized for 5 minutes.
I've been struggling with whether or not to even ask my prepared questions, mostly because I just want to say I'm sorry and to express my deep appreciation and gratitude to you all for sharing your stories, and also to your families for being there for your loved ones. And I know how hard this process is and how scary it is to tell your truth, so thank you. I served in the military myself and grew up in a military family, and so I know a few things about military health care. And I would like to understand better, maybe with my one question, from a parenting perspective, from a loved one's perspective, what could we be doing better to better integrate other people from a family into the decision-making process in healthcare and into, frankly, your experience when your daughter unfortunately did pass away and your experience of learning of her healthcare journey. I know that you're an adult. I know that your daughter is an adult, but I'm struck by this need that we have to make sure that we're also including people who may not be physically present in your family, but who might want to be engaged and involved in the healthcare choices and processes that you're going through. So I'd love to know from you all if there's any lessons learned that we can be taking advantage of. Before I let you answer, it's reflective, Madam Chair, of our experience with Vanessa Guillen and her family as well. Different circumstances, but just the same kind of feeling of these are young people who are experiencing medical trauma or trauma in general, and how can we better involve the family members?
Tell us the truth. Don't try to hide. We want to know what happened. It's just not right how they treated my daughter. And me personally, I don't want any other family to have to experience what we're experiencing now. Like I said, this has changed our whole life. Daily functions is difficult. Every day is a difficult day. My daughter should have never been denied medical treatment on the ship she served, the USS Ronald Reagan. That ship is named after the 40th President of the United States, and she wanted to serve on that ship.
Thank you, sir. And Mr. Barbara.
I think it's just accountability for myself and for other service members. The military isn't accountable for their actions. It's not fair to not only myself, but to my family, putting them through what they went through. It's sad, and it's something that shouldn't happen to anybody. When you're sick and you need medicine, you should not be denied the medicine. You should be taken seriously. I understand there's people in training that try to get out of training and try to fake it, but it should be taken seriously. Every single person should be taken seriously, because most of these people that aren't taken seriously aren't as lucky as I am. They don't have their lives anymore.
No, and this is the thing that I am also struck by is how young you are, how young your daughter was. I want to make sure that we're treating when somebody goes to the doctor, they're going because they're genuinely sick. It should be the going in assumption. And I know that that's not always the case with young people, and particularly people of color specifically. And so I think that's something that we should be very attentive and in tune to. Thank you. I yield back.
Gentlewoman yields back. The gentleman from Texas, Dr. Jackson, is recognized for 5 minutes. And my apologies to Ms. Escobar. You were in line ahead of me.
Thank you, Madam Chair. I appreciate it. First off, thank you to the witnesses for being here. Really appreciate your testimony. To you, Mr. Del Barba. I can't tell you how sorry we are for the disability and the way this has changed your life. For Mr. Lucky, our condolences to you and your family. I can't imagine what it's like to have your child taken from you at such a young age like that. Coming from military medicine, having been a military provider, it's horrifying to hear your stories, and I really appreciate you being here and telling us how this goes. I will say that, having come from military medicine, I can say that I think overall, the military does a fairly good job in most aspects with healthcare, but the stories that you tell are unacceptable. They can never happen again if we can prevent this. So we have to do everything we can to figure out how we stop this. I think that practicing military medicine is a very unique environment to practice in. Having come from that particular environment, I'll tell you, there's a balance between operational requirements and the medical training and competency that you're required that's different than if you were just practicing medicine out in the civilian sector. There are other time constraints and other requirements that you have to factor into your schedule that ultimately and unfortunately take away from some of your ability to provide maybe the best care that you could for patients at times. I think also it's complicated by the fact that in the military, and we all have to watch for this, and I know that the flag and general officers here from our medical community will agree with me on this, that it's difficult in military medicine sometimes to always be thinking about worst case scenario when you're really used to taking care of a very young and healthy population. And we don't see the population of patients that you see in the civilian sector with the very young and the very old and some of the really sick folks and some of the horrible, tragic things that happen to you, Mr. Barbara, and to your daughter, Mr. Lucky. Those are things that are more rare in the military practice environment than they are in the civilian practice. But that's on us to figure out how to fix that. That's on us to go out and make sure that we're getting that training out in the civilian sector and that we're exposing ourselves to that type of stuff so that we don't put your family members, your loved ones, in a situation where they're the victims of our inability to recognize those kinds of things. And I will say that there's a little bit of a component on us coming together with the three branches of the military recently, trying to combine and practice as one and learn how to approach things as one organization, not three separate organizations: the Army, the Navy, and the Air Force. So, Mrs. Salas, I was going to ask you a question. In your experience, is there any what part of the issues you were discussing earlier with the credentialing issues, the training shortfalls, the lack of quality assurance, things of that nature, how much of that is related to our efforts right now? I mean, we started this effort back in 2012, I think, to bring military medicine under one umbrella with DHA. How much of it is related to the fact that we still have not got there where we got everybody together under one umbrella, and how much is because we're dropping the ball because we have, we don't have clear responsibilities in certain areas?
Thank you for the question. I think it's very much related. I think that, and again, these are all preliminary observations from our ongoing work. The sense that we get from this review is that, one, the facilities generally are not adhering to a lot of the procedures for the, credentialing, provisioning, and the safety events and the focus evaluations, the things that we looked at. The procedures that were, the policies and procedures that were published, I think there's a lack of clarity around those procedures. There's definitely the sense of moving and trying to bring the different military services under DHA. I think there needs to be some clarification around the procedures and the language that's used in there. Some of the facilities were interpreting some of the language and the procedures differently. There was a lack of awareness of some of the different new procedures. I mean, this is 2019 when they were implemented. I think that a lot of the facilities are adjusting to that. I also think, at least at the DHA level, they are really still amping up their monitoring of facilities' adherence to these procedures. They're trying to still ramp up capacity. They are trying to determine what information they need, where that information is located, and then the tools they need to actually conduct the monitoring.
Thank you. I appreciate that. And I'll just close by saying, I do think it is a problem, especially when you're looking at our other providers, our medics, our corpsmen, our physical therapists, our PAs, things of that nature, with them taking care of the mostly healthy young population that we have right now. I know when I was a physician in charge of those types of folks, it was one of my biggest fears that we were going to miss something like that because the mindset wasn't out there looking for it. So we cannot excuse what happened to you and your families. We will try our best to fix this, to make this this right. And once again, I really appreciate your time for being here and telling us your story. It makes a really big difference. With that, I yield back, ma'am.
There are still 146 members that haven't voted. Would you like to go forward, Ms. Escobar?
I'd like to.
Ms. Escobar is recognized for 5 minutes.
Thank you, Madam Chair. I first want to say to Mr. and Mrs. Lucky how incredibly sorry I am for your loss. I cannot imagine what you all have had to endure. To Mr. Del Barba and his family, also so incredibly sorry for what you've endured. And it has taken, I know, tremendous courage to be here in front of us and to tell your story and to hold us accountable. And I really appreciate that you are doing that and that you are here to tell Congress that we need to do something. So we hear you loudly and clearly. I also want to recognize in the audience Myra Guillen, who is the sister of Vanessa, the late Vanessa Guillen. Thank you for being here. She's here with counsel. I have a question for Ms. Silas. Just listening to the litany of issues and the lack of following procedure and the amount of time that it's taken to understand and digest and follow policies and processes, I cannot wrap my head around why that is so. During this whole process, as you were taking a look at all of this, what do you think is behind that? Is it lack of resources? Is it a culture that refuses to change? Is it still too much bureaucracy? What are your thoughts?
I think that there's a couple of things going on. One is this is a massive transition that's happening, and it's going to require not only kind of putting the right procedures in place and the tools that I mentioned, but also it's going to mean a change in culture. And in 2000, it's been a couple of years now, and we have the policies and we have the procedures in place. There definitely needs to be a look at those procedures to ensure that there's some clarity around some of the language that's in there. I think the staff at the facility level is definitely trying to adhere to these procedures as well as they can, but the procedures are not necessarily written as clearly as they could be. And so that's leading to a lot of interpretation. And again, as I mentioned, DHA is still continuing to ramp up their monitoring. One of the things that I think we found in our review is, there's a centralized database, CCQuas, where a lot of the information around credentialing and privileging is supposed to be entered, but it also doesn't contain a lot of information or documentation that's needed for some of the other processes or procedures that are need to be monitored. So I think there's just still a lot of work needed to kind of lay the groundwork in terms of, a centralized data system where information is going to be, information is going to be put, and that DHA in their monitoring understands where that information is and then how to use it.
I appreciate that. It's just mind-boggling that it's taken the federal government this long really to do right by the people who are in our care, should be in our care. Well, a second question about the current malpractice claims process. How can we improve it to better allow for accountability and protections of victims of negligence?
Well, the scope of our current review does not include a review of malpractice claims. The new law that's governing malpractice claims is relatively new, and so there weren't any cases at the time within the scope of a time frame for our review to include them. So I can't really speak directly to that.
It would be interesting to follow, I think, to make sure that we understand going forward whether that is as efficient a process as needs to be, because key to account that is, in my view, a core function of accountability and a way for families to try to achieve some justice. With that, I'm out of time. Thank you all again, especially To the Del Barba family, to the Lucky family, really appreciate your presence here today. Your testimony was really powerful. Madam Chair, I yield back.
The gentlewoman yields back. There are 99 persons who have yet to vote, so 69. Oh, I can't read. All right, so we are going to stand in recess. It will probably be a little more than like an hour and 15 minutes because we have a series of votes, and then we will return and continue the questioning.